I am Dr. Dinesh Mondal, senior scientist in icddr Bangladesh, and also I am acting as a senior director of the Laboratory Sciences and Services Division since March 2020. Let me brief you about visceral leishmaniasis, a neglected tropical disease, parasitic disease spread by sandflies. It is a chronic disease with chronic fever, enlarged spleen, and anemia or pancytopenia. It is deadly if left untreated. Affected population are the poorest of the poor living in the rural areas of the endemic countries. VL victimizes children and adults, men and women equally. The countries most affected in the Indian subcontinent are Bangladesh, India, and Nepal. Outside of Indian subcontinent, these are Brazil, Ethiopia, Kenya, Somalia, South Sudan, and Sudan. You see in this slide, VL is a public health problem over decades in Bangladesh, India, and Nepal. In Bangladesh, 73,467 cases reported between 1994 and 2004. The question is VL is eligible for elimination? Yes. Why VL can be eliminated from the Indian subcontinent? This is because Leishmania donovani is the only parasite which causes VL in the Indian subcontinent. Humans are the only reservoir, particularly, the post-chalazodermal leishmaniasis. These are the cases which serve as an inter-epidemic reservoir of VL. Diagnosis available. Safe and effective drugs are available. Sandflies susceptible to available insecticides. So, based on these facts, unique epidemiological feature of the disease in the Indian subcontinent, the World Health Organization and TDR succeeded to convince the Ministry of Health in Bangladesh, India, and Nepal. And as a result of this, the political commitment for VL elimination from the Indian subcontinent came out in 2005. And it was decided to reduce VL incidence to less than 1 per 10,000 people at Upozila, which is equivalent to sub-district in Bangladesh, block district level in Bangladesh, India, Nepal, respectively by 2015. Unfortunately, it was not possible in 2015, and later it was extended up to 2017 in 2014. What were the key elements of the VL elimination program? These are effective disease surveillance, early diagnosis, complete treatment, and integrated vector management. But how to do that? Yes, for the effective disease surveillance, active case detection was the solution. Here you can see one of our research work, active case detection in National Visceral Leishmaniasis Elimination Program in Bangladesh, India, and Nepal, feasibility, performance, and cost. Here you can see the key implementation research findings. Active case detection helps detection of more women and children with VL and reduces delay from onset of symptom to treatment. Active case detection is feasible through the frontline public health personnel of the national programs. CAM-based approach is cost-effective for the attack phase of the program when VL burden is very high. And index case-based approach is cost-effective for the subsequent phases of the programs. Just for your information, the program has 3 phases. One is the attack phase, when the VL burden is very high, and then consolidation and maintenance phase, when actually VL burden comes very low. sorry. Yes, our implementation research findings on active case detection have been taken up by the national VL control programs and incorporated into the national elimination guidelines. What about the rapid diagnosis? Earlier people diagnosed VL with DAT, direct agglutination test, which cannot be done in the field. People with VL, they are living in the rural areas. So you have to have a diagnostic kit that permit you to make the diagnosis at household level. And fortunately, we had RK39 point of care test, and research findings on rapid diagnosis of VL with RK39 point of care test have been taken up by national VL elimination programs and incorporated into national guideline. Why? Because the multi-country studies in Bangladesh, India, and Nepal funded by TDR demonstrated that the sensitivity and specificity of this rapid test for diagnosis of the new VL cases was more than 95%. So the program was happy, and this diagnostic tool was taken by the national program. But what is the problem with the RK39 rapid test? It is very good for diagnosis of the new VL cases. But in case of relapse of VL, what is happening in the consolidation phases of the VL elimination program, when the number of the new cases are low, you cannot use RK39 because it detects antibody, and antibody persists among past VL cases for years. So you need molecular diagnostic tools. Through research, we have evaluated PCR, LAMP, RK28 ELISA, and RPA through mobile suitcase. All these tools are effective for diagnosis and confirmation of the VL relapse cases. And program is very happy, and they have included PCR-based test, particularly the real-time PCR test, in the national program for confirmation of the diagnosis of the VL relapse cases. Yes, we actually found the way for finding the cases, diagnosis the cases, but what about treatment? The sodium stevogluconate was only option for treatment almost for century. We have only one drug. Fortunately, after the initiation of the VL elimination initiative, the miltefosine, the only oral drug for VL treatment, and subsequently the liposomal amphotericin B came up. Professor Shamsundar and his team in India demonstrated that in 2012, demonstrated that the liposomal amphotericin B single shot was highly effective and safe for treatment of VL cases, but it was in controlled situation. The liposomal amphotericin B needs cold chain, and also it needs trained doctors and nurses for its application. Is it possible to implement it in the rural hospitals? Nobody believed before this research. We did the research with the support from TDR and NTD-WHO. Our implementation research confirmed the feasibility of implementation single-dose liposomal amphotericin B in rural primary care hospitals for treatment of VL. And since 2014, it is the first option for treatment of VL cases in Bangladesh and India and in Nepal. So it was really breakthrough for treatment of VL cases in the Indian subcontinent. Now, one of the most important pillar is the vector control. VL transmitted by the sandflies, the vector of VL. So one of the pillar for the elimination strategy is the integrated vector management. What was happening in 2008 in Bangladesh? Through research, we found that nothing was there regarding vector control, even regarding the activities of the VL elimination in Bangladesh. Though the political commitment came up in 2005, but it was 2008 when the elimination activities started in Bangladesh thanks to this implementation research in Bangladesh, where we demonstrated that there was no vector control activities in Bangladesh, there was no national guideline, there is no technical advisory group, But after this publication, it sensitized the policymakers at the region and also at the national level. And the VL elimination program, mobilized, and they started, the national guideline came up, the technical advisory group was formed, etc. But the problem was that, in 1980, DDT was banned in Bangladesh. So practically there was no insecticide to control VL vector. Then we conducted implementation research. It was a randomized control trials in the 3 countries. And we found that deltamethrin was wonderful and very effective to control sandfly in Bangladesh, and alpha-cypermethrin was effective in Nepal. So the national program in Bangladesh, incorporated into the national guideline deltamethrin for indoor residual spraying to control sandflies in Bangladesh. But there are some problems, some challenges with the indoor residual spraying with deltamethrin. It is expensive. It requires trained personnel to deliver it. Requires procuring, maintaining equipment and supplies. Needs to be repeated at least twice a year and has short duration of efficacy. So what could be the alternatives? Through implementation research, we already proved that yes, it is insecticidal wall paint. You can see in the left side. Then durable wall lining in the middle, and the insecticide treated bed nets. This could be, the alternatives of the IRS in the consolidation and maintenance phases of the elimination program. So in fact, when we disseminated the result, the program liked very much the insecticidal wall paints, and hopefully, they are hoping that this will be available in Bangladesh and will be produced locally so that the program can afford it. We researchers are working with the national program in the past. We are now working and will be working in the national program hand to hand. We delivered all our research findings to the national program, and national program was very happy to adapt those research findings into the policy. And as a result of that, now we can see today these beautiful pictures of VL burden in Bangladesh. Today, you can see as of September 2021, we have only 70 cases of VL, and most of the cases are VL relapse. The number of the new cases are very, very few. On the right side, you can see all 100 endemic upazila or sub-districts, VL endemic sub-districts, and everywhere the incidence is now less than 1 per 10,000 population, and it is sustained since 2016. So now the country is ready, and the program is preparing to apply to WHO for the certification of the VL elimination from Bangladesh. In conclusion, implementation research has generated evidence for implementation of the strategies of the VL elimination program. Evidence has been taken up by the National Elimination Program. VL elimination target in the attack phase has been met and sustained. Evidence now required for consolidation and maintenance phases of the national program. I am very much thankful to my excellent team. We are very, very grateful to TDR for their excellent support for us, for the national program. We are also thankful to our core donor of icddr. Thank you very much for your patience. Thank you.